Okay, let's wait another minute. In the meantime, if you want to introduce yourselves in the chat, please just go ahead and we can get started very soon. I think we'll get started and hopefully any others will just join very soon. So hello, everyone. We're really happy that you could join us today. My name is Soumya Alva. I'm the Senior MEL Director for the USAID-funded Momentum Knowledge Accelerator, and I'm a Senior Research Monitoring Evaluation Advisor with CHIME, which is a Center for Health Information Monitoring and Evaluation at JSI. Today's webinar is hosted by the Momentum Monitoring and Evaluation Innovation and Learning Working Group. As many of you know, Momentum is USAID's flagship suite of integrated projects that work alongside governments, private and civil society organizations, and other stakeholders to accelerate improvements in maternal, newborn, and child health, nutrition, voluntary family planning, and reproductive health. Using a more targeted context-specific approach, Momentum works to strengthen the capacity of a number of stakeholders to create demand for, deliver, scale up, and sustain quality evidence-based interventions. So the Momentum MEIL Working Group, as we call it, serves as a platform for collaboration and discussion that brings together leaders in measurement, innovation, and learning from across Momentum, tapping into expertise from external partners and working groups as needed. We aim to provide technical guidance, build consensus, and routinely review what to measure and different approaches for measurement, analytics, and visualization, learning, and innovation for use across Momentum, thus strengthening measurement and learning across all projects. My colleague, Megan Ivankovich, co-leads this working group with me. Meg is a Senior Learning Director of Momentum Knowledge Accelerator and also a Program Director with the Population Reference Bureau. So we have a very interesting presentation today on data use for service improvements. As we all know, effective coverage is defined as the proportion of a population in need of a health intervention that receives it with sufficient quality to achieve the intervention's intended health gain. While there are several approaches that have been used to measure effective coverage, most are statistically derived. They're based on triangulation of multiple data sources and use complex analytical approaches. So about a year ago, in July 2023, we facilitated a conversation about the challenges and lessons learned from applying effective coverage to monitor quality service delivery and data use for service improvements. This was based on the experiences of the WHO in the Western Pacific region and the government of Laos to monitor quality service delivery and use data for service improvements. Today, we're lucky to have Dr. Shogo Kubota again to share progress made on the WIPRO office's approach and examples from countries in the region in assessing and improving the quality of healthcare and systems, while also strengthening the underlying health information system that provides this information for monitoring healthcare quality. So I will pass on to Dr. Kubota in a little bit, but following his presentation, we will have some time for question and answers and a discussion. A little introduction on Dr. Shogo Kubota. Dr. Shogo Kubota is the coordinator of maternal child health and quality safety for the WIPRO region office. He leads the team in supporting countries in the region in improving quality, safety, maternal and child health, infection prevention and control, emergency, critical, and surgical care. For the last 7 years, from 2016 to 2023, he served as the team lead of the Reproductive Maternal Child and Adolescent Health Unit for the WHO Lao PDR country office, where he supported the government on maternal and child health, quality of healthcare, and community engagement and multi-sector governance for health. He's a pediatrician by practice, Before joining public health, he worked in humanitarian, that's post-disaster management, refugee camps, etc., with Red Cross. And he had a different life before the Red Cross. Before medicine, he studied religious anthropology, the learnings from which he has found very useful in his current public health work. So before we get started, I just want to go through some housekeeping points. Thank you so much for those who've introduced themselves in the chat. If you haven't had a chance to do so, please go ahead and do that now. Please keep your computers and phones on mute. For bandwidth issues with people joining from different locations, it would be good if you could turn off your video and stay off camera. However, please feel free to turn this on when you are asking or responding to a question. As you may have noticed, this webinar is being recorded, and after the webinar, we will put it up on the Momentum YouTube website and share it with all the participants. Finally, throughout the webinar, you can ask questions using the Q&A function. Please don't add questions in the chat because it's going to be hard to follow. And in the Q&A, you'll be able to see everybody's questions and upvote or like or other people's questions as well that you want answered. And we will try our best to answer all the questions at the end of the webinar. Thanks again for joining this session. And I'm going to pass this on to Dr. Kubota. Over to you.
Thanks a lot, Shmiya. Hi, everyone. So this is Shogo from UPRO here in Manila. So today, I would like to share our experience in UPRO's work around measuring quality of RM and CH, but also beyond, because we do cover other areas such as infection prevention and control and surgical care. So next slide, please. So I think this one, many people know already that there was quite a shocking report that says more people are dying from low quality than non-utilization. So there are people who are dying because there is no access to service, but there are more people dying because they have access, but the service quality is poor. Next slide, please. And yet, what do we monitor in SDG 3? Basically, three things: health outcomes, mortality, morbidity, and service coverage, and health behavior, such as consumption of alcohol. So that means even though there is a big impact of low quality in health outcomes, we are not globally and systematically. There are many work going on, yeah. But we have not been systematically monitoring the quality in many countries. Next slide, please. So you can see that reflected into the health information system in many countries. So what do we measure? What do we look at when we want to prioritize, the 5-year strategy in the country? So we look at health outcomes, we look at population data, we look at service coverage, and we want to look at service quality. How do we look at them? One click, please. So we can, will you click? Next, yes, thank you. And one more click, please. So for population and the survey base, we have census. And for the routine, sorry, it says health information, but routine reporting, there is a CRBS. For health outcome and service coverage, 2 clicks, please. For survey base, yes, we can use census to some extent. We have DHS, we have MIX, and routine based, many countries has HMIS to report, for example, utilization, the coverage, which you can calculate the coverage of services. And one more click, please. So what about for 2 more clicks? I mean, 1 more click, please. What about for quality of care? What are the ways? So one of our priorities in Western Pacific regions in terms of improving quality of care, supporting the countries for improvement of quality of care, is around establishing a routine mechanism to monitor quality, either through survey-based or through routine monitoring, routine reporting. So we both work on both sides. For example, in Laos or in Cambodia, we are working with the government to integrate some of the quality indicators into a self-report HMIS. And together with an external survey to have a routine monitoring. Of course, this one is expensive and it requires a big workload. So as it is the case for census, DHS, and MIX, this one happens only every, for example, 5 years. In the case of Laos, which I will talk a bit more in detail. Next slide, please. So when we say quality, what do we mean? We mean as a Western Pacific Regional Office, how we work on quality. First, defining what's the scope of quality. So it's a theme, a few clicks, 2 clicks, please. So one is, of course, what we want to see. So these are the expected functions at each level in terms of continuous quality improvement. At the individual providers level, we expect technical competency, that's knowledge, attitude, and practice. And then at either at the unit department level or at the hospital level, we expect to have a continuous quality improvement mechanism in place, having a regular quality monitoring and planning. And this regular quality monitoring, this is what we can contribute by working around HMIS, having a quality measurement in a regular manner, such as every month. And things like PDCA cycle in place. And when there is an event, there's an event investigation, whether it's MDSR or if it's IPC, it can be a hospital-acquired infection outbreak, that kind of stuff. So, and then one more click, please. And also, there is a lot that we expect to the hospital managers on governance and having a policy in place, the governance structure in place, such as patient safety committee, quality improvement committee, IPC committee, so on, action plan, budget, M&E, and having a service readiness, such as medicines, equipment. And also, its workplace culture is a very important one. We are working with hospital managers around workplace culture, workplace culture, and also safety culture. I forgot to write safety culture. So, you know, what's important in improving the quality or measuring the quality or our safety, we have to feel very comfortable to say, I messed up to my supervisor. So we are working with hospital managers on how to establish this psychological safety or safety culture where we can freely say, I messed up. So these are the work to support hospital for quality improvement. There is a work around networking, so that network of care, so referral care, remote consultation. So to connect different hospitals as a whole team in a district or subnational level. And then also, one more click, please. There's a lot of functions to be expected at the national level with Ministry of Health in having a policy in place, regulation, licensing, accreditation, strategy, again, governance, plan, budget, M&E, and also having a national quality standard being reflected to pre-service education, in-service educations, essential medicine list, and all sorts of things. So this whole thing is what we call quality, and we work in different areas of this. And I will from here go into a deep dive on from experience in Laos, and hopefully I'll have some time to also introduce some other countries as well. Next slide, please. Okay, so this is an example of there I can see some of the colleagues from Laos also joining who are working on this. In 2019, they have started the first round of nationwide quality assessment and improvement support at every province. So there are 17 provincial hospitals, 130 district hospitals, and about 1,000, a bit over 1,000 health centers. This work has been done targeting mainly in the province and district hospitals. So objectives includes identifying the situation analysis, identifying strength and weakness in service quality, and by jointly, so the external facilitator, for example, for the district, there will be a provincial facilitators coming to a district, and together assess the quality, review the care, and analyze the data. And also at the same time, there is a supervision or technical support, on-site technical support to the individual providers. Usually this is done in a few days, and then that all while reviewing the quality, there is immediate interaction, immediate feedback to the providers for improving the practice, as well as that data is compiled and used for action plans for the facility. And then each district hospital's data comes to the provincial level and also to the national level for data used for strategies, plans, and policy making. Next slide, please. So this is how the assessment is done looking at the readiness, such as policies, human resource, medicines, sorry, it says medication, medicines, equipment and programs in place or not. So that's through staff interviews and also direct observations for some of the, for example, equipment or medicine. And then providers' knowledge is looked at through clinical vignette, and then the provision and the experience of care through exit interviews, the chart reviews, the re-examination and direct observations. Next slide, please. And so the first objectives on site technical support happens right after, immediately after this observations or clinical vignette or chart reviews, and by a trained facilitator. So these facilitators are trained to support, to improve the quality, but also really motivate. There's a coaching, training for them, so that there is not only a technical content, but also motivating the individual providers. And yes, so next slide, please. And then the data is compiled, analyzed, feeding into the flip chart dashboard, discussing root causes, solutions, and actions, which are presented by the providers in the facility to the hospital managers and others. Next slide, please. And those are all coming together, compiled again for provincial database planning in all districts together in one province. And then, because there are 17 provinces, those comes to a national level for the long-term strategic plan. So what are the examples of these? Next slide, please. So this is it's a scoring from one province, which has 10 districts. So Houaphanh province, you can see each district routinely doing this assessment in 5 different areas: the reproductive, maternal, newborns, well child, and sick child. And you can see the trend of each district hospital. Next slide, please. while the scoring is one thing, just to see a trend, what's important is because it has such a rich information about quality, they looked at different data, for example, disaggregated by ethnic groups. So this one is an interesting one. You see the inequity. I mean, the Margaret Cook's report also talks about inequity in quality, but for Lao context, the inequity, what was the concern was the inequity among ethnic groups. So what we see here is a discrepancy between provision of care and experience of care, or I don't know if we can call this experience of care, but what the gain actual benefit for the users. So in the exit interview, there is a question. So have you gotten, did the provider give you counselings around danger signs on newborns? And you can see across different ethnic groups, most of them said yes, they talked about it. And the next question is, what are they? Will you tell me what are the danger signs? And this is when you see the difference. So Lao Tai is 70% can answer at least 3 danger signs. On the other hand, Hmong Mien only said 40%. So then that is reflected into a national priorities around how do we do counseling for those who do not speak Lao language. This is one example. The next one, please. So equity became one of the 3 big strategic focus in the following strategies. And this is another example of what we can look at. This is a missed opportunities. So out of 400 children who came for immunization, almost 80% of the children missed opportunity to receive essential nutrition services such as screening on breastfeeding and complementary feedings. Some people are coming all the way, taking 2 hours to the hospital and get the immunization. There's a good opportunity for all the other services they can receive, but they missed opportunity. So this is reflected into, so I'm going to talk of maybe 2 examples around how this bottom-up, a very bottom-up, from district hospitals to 17 provincial hospitals all the way to the national level, how that bottom-up quality assessment and also using that for improvement in each level comes up to the national level for the change in at the national level. So the next slide, please. So this missed opportunity was highlighted, and that was concluded as a reason that the conceptual framework and how the governance structure in RMNCH committee was more on wide program. As you see on the left side, there are 7 subcommittees based on program. And one of which was immunization, one of which is nutrition. This is pretty much due to how the donors have divided, and it was together in the past in Laos, but it was divided, and this is very much a donor-driven silo program that has divided these, and you can see the result of this missed opportunity. So the current strategy, which started in 2021, has reformulated into 5 subcommittees based on target population. So now there is a subcommittee on well child instead of having nutrition, IPC, and early child development. And that is reflected in SOP, that is reflected into a standard for accreditation and so on. And also, for example, maternal handbook. So before you open the handbook, the maternal handbook, MCH handbook, you open, there is a page for immunization. You open another page for nutrition. But now you open, there's a page for a baby with a 3-month-old baby. There's a page for 6-month-old baby. So that's the change, the shift that has been made using the data. Next, please. So this is the last one. One more example from Laos is around how this again, bottom-up quality improvement has made a big impact in regulation of midwifery scope of practice. So this is a story in one of the district hospital. The facilitators, together with the midwife working there, have interviewed 10 women as a part of the exit interviews. Only 2 out of 10 got their blood drawn, blood sample taken. So that was presented by the midwife to the hospital manager as each 5 area has a big, flip chart and as a dashboard and present a lot of things, but one of them was about this. And the hospital manager stopped her and said, why only 20% get their blood checked? And the midwife smiled and said, well, why you don't allow us to order blood? It's only doctors who can order blood samples. And do you think we have doctors in antenatal care clinic? And the hospital managers, the director smiled and said, well, you are allowed, and please take blood from tomorrow. So we thought, oh, this is a good example of how, the management influencing the management. But then MOH staff, we were talking, are they actually allowed? The ordering test, are they allowed? So we went back and looked at the essential service package, and then start to compare, did a gap analysis. How many of the interventions that essential service package expect midwife to provide without doctors are actually allowed legally? And we found only 20% were allowed. So basically, the government at that time is saying, you have to provide this, but we don't allow you legally, nor do we protect you legally. It took only 2 weeks until all the scope of the midwifery were revised, and more than 90% became legally allowed. And this is a really strong example that my country in Japan is struggling to have expand the nurse and midwives scope, the autonomy without doctors. And so this is a really strong example of what the quality measurement can actually influence a legal framework at the national level. Next slide, please. So now these are the 5 different tools that Laos is using. I'm going to a regional level now. The next slide. Okay. So these are different tools at the regional level. So a lot with early essential newborn care, but also there are quality assessment and improvement support tools for example, here you can see preventing unplanned pregnancy, family planning, and also care for infant and young child, and so on. And on the middle, you can see this first biennial progress report, second, third. Then what's in here is on the right side. So you can see this quality profile of each country. You can see from the top, Cambodia, Laos, Mongolia, PNG, Philippines, Solomons, Vanuatu, Vietnam, China. So these profiles are available every 2 years because of this routine facility-based assessment. Again, this is not for assessment, it's for improvement support, but as a byproduct, we have a good data to monitor how the trend of the quality of care. Next slide, please. Now we are expanding this method for different areas, such as in IPC. This is in Solomon, because they requested us to support our outpatient IPC before they had a big national game, no, Pacific game. And again, it's saying we start really from the point of service. So we do this simulation based. So we see this is a mock patient who is a staff in the hospital, go through a scenario, and then all together review a gap between the standard and the practice, as well as not only practice but also environment. And then we discuss what to improve. Then later on, not only with the technical team, but also with the managers, we talk about IPC. What do we have in terms of IPC management? Do you have governance structure? Yes, we have committee. Great. Do you have TOR for the committee? Yes, we have TOR. And do you meet regularly? Yes, we do meet regularly. Sounds like good. We have a governance structure, and yet there is no soap on the sink. So how does this management and the actual practice or environment, not as simple as not having soap in the sink, how that link? So we support, the next slide, please. So what our support, again, click 4 clicks, please. So it's a similar slide as the first one, but this is more translating into what is our support. We do support in these areas. And what's important is that we link the governance with actual practice. How, there is often a bit of a discrepancy or this link between management, quote management, and the practice, but actually management is for improving, supporting practice. So we try to support linkage of them. One last example, and I'm finished, is from Cambodia for IPC. So on the left side, you can see that we worked on a scoping review, looking at what functions of MOH do we already have in terms of IPC, policy in place, regulation in place, and so on. And then identify what are the 8 points for improvement. What they identified as specific points for improvement after the scoping review at the national level was education. So pre-service education does not yet cover all the IPC competencies, as well as MNE. MNE for IPC is very difficult, as you know, how to monitor hospital-acquired infection. So that was reflected into a national 5-year strategy for IPC. And then now we are supporting actual strengthening of, for example, reflecting into pre-service education, as well as establishing a many framework. At the same time, we have support at the facility level. And now we discussed, I just came back from Cambodia yesterday, and I see Cambodian colleague also here. Very, very nice to see. So we just discussed that, okay, these things are coming together, and yet we can, and also because the minister has a very strong priorities on hospital leadership, we said we could use that opportunity for strengthening leadership and also making us establishing this safe culture. Because as you can imagine, hospital-acquired infection is very difficult to really get real data, because it's not something you want to openly say, hey, we have many patients who came into the hospital without infection, now having infection. So this culture and the leadership is a very important of our support. I think this is the last slide. Next, please. That's it. Yeah, okay, yes. So we are supporting in quite a comprehensive the quality measurement, as well as improvement from the individual providers level all the way up to the national level in the different areas. So if anyone's interested, let us know. Thank you very much.
Thank you so much, Shogo. That was a really interesting, useful presentation, and thanks for walking through the whole process of, how, WHO follows this integrated quality improvement approach, showing the example of Laos, and how you can do continuous quality improvement, using, getting information readiness, but also using methods like exit interviews and observation, staff interviews, etc., and vignettes to capture the information we need. And an overview of the different tools that you have used in Laos and in other countries through the office. So we have a couple of very interesting questions here, and please feel free to add any other questions into the chat. So I'm just going to go through these now. The first one is about ensuring accountability in the health system, hospitals, facilities, etc. So, this question from Nilofer says they have a lot of data, but, and you talked about how WHO provides technical support. Beyond that, there's a whole facilitation process to see how you can use these data. But they're having challenges on how to be able to actually use these data to make improvements in the health facilities, especially because, if quality challenges are a result of a complex set of issues. So any insights into that would be helpful.
Do I actually see the chat?
You can see the questions in the Q&A if you want to read it.
Q&A, where is that?
If you press the more. And the
okay.
Yeah.
I see. Thank you.
It will come.
Okay. So about the use of data, one thing that I do want to emphasize is, we often talk about, I think we hear often that we have to feed back the data to the facility. And I would not actually agree. We should not have to feed back the data because the data has to be used in each level before it's aggregated. Once it's aggregated, you feed back it to the it's hard to use for the facility because each facility has different challenges. Yes, there are things that are common, but still, it's and how you relate to the data becomes very different when you get one day unaggregated data from above, so when the data, one important thing is that in the same visit, we do the quality assessment together with the facility providers and some part with the managers. So the raw data is coming from their own assessment that is written, drawn into a flip chart and used for bottleneck analysis. And then, so the data is already used in the facility for planning, and that plan is used for monitoring in a regular basis. And that's the difficult part also because external, supportive supervision visit is quite limited. And that's the reason we also work on this establishing a mechanism in place for continuous improvement at the facility. So I think that's really the emphasis of our work in terms of helping usage of data. We do a lot of work around how to analyze data and so on.
Yeah.
Did I answer the question?
Yeah, I think Nilofer wants to push a little bit more on accountability from the perspectives of patients. Nilofer, do you want to just get off mute and just ask your question?
Yes, sure. First of all, thank you for your presentation. I'm myself quality improvement practitioner, and by the way, I led a project in Cambodia called Enhance Quality of Healthcare Activities for 3 years. Now it still continues. It's a great project, supports Ministry of Health in accreditation, pre-service education, quality improvement collaborative, and contributing to some of the things that you have highlighted. What I liked about your example is that very often quality improvement is bottom-up driven, through this QI, because that's where quality happens. That's where patients receive specific services. And what happens oftentimes, like you said, donors support these projects, multiple projects in a fragmented way, and then the policy level does their own in a fragmented way, and there is no connection. But what I liked about the examples that you have provided is that you are tending attentively to what's happening at that facility level, and then you are bringing it to the policy level and saying, okay, how can we use that information and make a change at the institutional level so more patients benefit from, like you said, a very great example where because nurses don't prescribe, then a lot of patients are not benefiting. So it's very powerful. And then there are other also examples. And I think that that's the value that I see And we need to bring that interconnectivity between things that are happening in the facility level, in the projects, in the policy. That interconnectivity should still be enhanced. But one of the problems, challenges that I saw from my work of 18 or 19 years of quality in low middle income countries is accountability. Yes, we collect a lot of data. Probably we collect more data in low middle income countries than in United States because we have to satisfy not only requests from the Ministry of Health, but also USAID and WHO and Global Fund, etc., etc. It's just this is the reality. And then the projects. So data, I think it's great. And again, what I loved about the example, use the data to make decisions and make changes. But accountability still is an issue from the perspective of a client, a patient. When the error happens in that moment, there are no mechanisms to kind of empower and bring light to that error. And then accountability, both small errors, big errors. I will tell you just one little example. I'll not tell from which country. I brought together patients and facility doctors, and I said, hey, patients, are you happy with the quality of care in that facility? They said, yeah, we're happy. And I said, well, is there anything that can be improved? They said, well, no, everything is fine. I said, well, maybe you've heard from other patients that something can be improved. And then the patient said, well, once I was given an injection and then it started hurting and I called the nurse. I said, can you remove or do something about it? The nurse said, that's not my shift. The next nurse will come and take care of it. But I could tell by looking at the face of a patient that that happened to her, not to someone else. And then the facility manager who was at that time there, he said, well, thank you for sharing that. I will make sure that, regardless of the shift change, if the patient needs something, the nurse attends. So it's just a little example of these things that are happening a lot, and how can we enhance accountability in the healthcare system? Thank you very much. It was a very, very long question.
No, that's a very, very, very important point, and thank you very much, Milva. One thing that we do emphasize is this creating, you said connectivity, I think. Creating this sense of we are on this together, right? So one thing about this planning is not only writing about, okay, what facility needs to do or what providers need to do. There are things within the same, and this is going back to the scope. Why do we have to really show the whole scope? Is because then you realize, improving quality is not only about any one individual person, but it's the providers, it's the managers, and it's the Ministry of Health all together makes this possible. So, and it's actually I did not mention anything around community engagement for quality, but that also what we find. Again, I want to draw an example from Laos. Is when we work on worked in community, oftentimes, okay, when we say, okay, why would they not coming to the health center to use service? They want to say it's because it's dirty or because they talk rude, and there is a bit of if we don't navigate well, sometimes there is a bit of tension. So what we do is a lot of different types of, the trust building exercises, and then have this team as a together and said, okay, so we are on this together. We're talking about health of the people that we work on together. Then you have this soft, the relational aspect, which really tight, strengthening this accountability. Yes, we can talk about more system approach in terms of building accountability, but I think this relational aspect is so big in quality improvement and beyond.
Yeah.
Thank you.
Thanks, Shogo. There are a few questions here. I'm going to go through them quickly, and if we don't get to all of them, we'll try and send responses when we share the presentation. So this other question is on getting the means of getting community feedback on quality of care, and the exit interview is the best way of getting this information. Are there any other good practices other than the exit interview? And secondly, can we apply this methodology even with community health workers, even below the facility level? Yes. And have you done this before? How do you do that?
Yes. Okay. Yes, we have worked a lot with the communities. And two things. One is around feedback. I think you can talk about feedback through, yes, we can get feedback through exit interview. We can get feedback through, the opinion box. But that's a feedback. And I think what we need for the real engagement of the community happens in the community. My personal experience in having, we tried to have the voice of the community within the hospital, and also even training. We asked, for example, mock patients to support the trainings. And what we realized is really the best way for capacity development for the providers to get the real good insight and the engagement from the communities. We go there instead of we bring them to here, because that's where they work. That's where they feel comfortable, and that's where they have all the colleagues, friends. So the way like when we and then we started some capacity development of the trainers within the community, and listening to we set up this focus group discussion where women's talking about why they don't want to, or deliveries. And then one, I remember just an example is in one village, they were saying, well, but because we don't know if that day there are three people in the whole facility, and one was guy, and two was woman. And because we don't know if the day I go is with men, and we don't want the man, and we don't want our husband don't want the man to, check us. Then that discussion happened right there, saying that, okay, you know what, we all live, and this was a good, there's no tension. It's more like, that's true. And this guy was there, and that guy was saying that, we all live in the compound, which is right next to the health center. If that's the case, just let us know, and then we can switch. That's it. So you see all this, that's the community engagement, which might not come out just by someone doing the exit interview in the hospital or getting it in a box. So there is this, because there are more community, the villagers than the facility workers, that was their space. They can be quite intimidated when they are in the hospital. So we found that there is a lot of in the community engagement. We do have to go to the community. And I think there was one more. Sorry, I forgot what was the other one.
Yeah, no, I think that's fine. Let's just move to, so sorry, I can go back to that. So the question was also, can you apply this method for community health workers?
Totally.
Not just the facility.
Yes. Okay. So again, the methodology itself that I have just described is one thing. Yes, for sure, you can apply in any different ways. But I think what's one important thing that we just discussed, and I want to emphasize again, is around the relational aspect of human beings. I think this having a trusting relationship is so important for anything, but for quality improvement, and for this kind of approach can be done at the community with the community health workers as well. Talking more of a technical aspect, yes, we should of course simplify a lot, but when we find what do they care? We can start from there. What do they care mean is what are the quality that the users care in terms of working with the community health workers, and then we can use that as an entry point for quality measurement. But I would say, I wouldn't even say this as a quality measurement. It's more like building this, we are on this together again, the villagers, the community health worker, and also the ones who will be supervising these health workers. You make this, community of working this together for the health of the people. I think that's really the core.
Yes. And thanks so much. Thanks so much, Tomomi, for your comment in the chat as well about what you've done before. So I'm going to move on to another question here. One is from Lara on data visualization. How did you select them? And were the users involved in selecting and presenting this data?
Okay. So the first one, to be honest, users weren't involved. It was more top-down, saying these are the indicators that the Ministry of Health want to monitor. But what we've found is that as we go, there are certain indicators, because when the first round really makes a huge difference in the ownership of the tool, right? And then you say, and especially when you analyze and say, okay, I want to know more about this one, okay, we know it's good. So we start to, all of us, the users, no, not the users, still the providers and the managers and the MOH staff start to prioritize what kind of quality they want to know more. For example, about the counseling, because they found a big issue around the counseling. So more and more questions and analysis and hence data needed for counseling skills. So that's how there's an adjustment. Even though there is a regional tool, there is a lot of, you can see across this, for example, for newborn care, there are across 9 countries, it's been introduced in more than, in the 2020 already, 7,000 facilities, so a lot more by now. We have to see the numbers, but so there is a lot of variety in the tool, which is great, even though we do have some regional core indicators that we negotiate to please keep. So I think that's the progress and the evolution of the quality measurement based on the priorities they find. Now, going to the next question of did we involve the users? I have to say no, and that's a great question that I think we do have to take back and see what we can do about it. Community engagement work, yes, for sure. Yes, a lot of it's really coming from the community, and the same method but different. It doesn't have to be. It's not always for sure MCH. Sometimes it's about supporting the aging couples, and there are different needs, and then still using one approach. But one thing about community is that we construct intervention only with questions. As Sumia, thanks. My background around anthropology in before medical studies. So there is this one anthropologist called Lévi-Strauss. It's the same Levi-Strauss, but the French anthropologist, who said the scientist is those who has good questions, not answers. So we have, for this community work, we have actually constructed in interventions only through questions. Then it's adaptable, but then it's scalable. Sorry, it's a bit of a sidetrack. Let's go back, sorry.
Okay, we only have a couple of minutes, okay. So I'm going to go to one more question from Ankur, and if we don't get to the other two, we'll send responses. But This question builds on the question of accountability in data use, basically saying we have good examples of quality assessments being scaled, but scaling improvement efforts is much harder. Do you have any thoughts on scaling improvement efforts based on quality assessments that are done?
That's a good, I think this question comes back to what I just said, actually. So I wasn't off track, right? So why is it? It's because assessment, even though it's not, assessment is quote easier because you have a standard checklist and you can assess and you can scale it up. But that's not what we are actually expected to do, even for the assessment, but especially for the improvement, because we are working with very different situations and localities. One of our data we got from this, maybe I don't have time for this. Okay, let's for the improvement. So I think what we are scaling up is not answer, right? It's an approach and a question. And what is this approach? Is about, for example, the often used fishbone analysis. That's an approach, and we don't have the answer, but that approach can be used in different places. Same. So what is the training that we do for the facilitators in terms of feedback is around how to give a positive feedback and without intimidating the providers to assess, motivating and yet help them to get what has to be improved. So I think it's the scaling up part is same as what I said about this community engagement. What is the essence of what we are scaling up isn't the answer, but question. And it's an approach. It's about approach on how to build relationship. It's an approach of how to say, we are on this together. Quality improvement is not only me telling you, but I'm also responsible. They're also responsible. That kind of, soft skills is, I feel it's so important in this area. So I don't know if I have directly answered the question, but I think the essence that is scalable is more about our approach. Thanks.
Yeah, thanks so much, Shogo. And I'm sure like you said, your anthropology experiences all come into all of this work that you're doing, and it's important to think beyond just the health clinical aspects. So I think we need to wrap up. We're at time right now. So if everyone could take a minute and just answer the survey that is in the chat, that will really help us identify other topics for this conversation. Discussion on measurement, quality improvement, and so on. And we do have a couple of other questions here in the chat. We'll try and respond to them when we send the recording out to the participants, because they're great questions out here, and include, answering the previous questions that were there as well. So if we have any other insights. Thank you, Shogo. This was a fantastic presentation and great to walk through the Laos and the other examples. And I think it's reflected by the questions that came. Few questions, but very meaningful questions, thoughtful questions that are very useful for us. So thanks again, everybody, for joining this conversation. Please be in touch with us if you have any other thoughts on this topic, any other questions that come up. Our email addresses are here. If you have any others who are keen on working with Shogo, or feel free to reach out to him directly. Any other topics you want to hear in terms of webinars, we'd be happy to present them as well. Thanks again for joining us from the world over, especially from Asia. It's quite late in the evening, and thanks, Shogo.
Thank you very much. Thank you, everyone.
Yeah, bye.
Bye.